Perhaps if I can start off just with something that hasn't come up in the Q&A, just related to COVID, and obviously there's a lot of threats in the context of COVID with respect to preventative cardiovascular medicine. But you touched on it at the end then, and this is relevant to both you, Gary, and to David. I mean, do you think there are any opportunities that COVID presents us with that means that we may be able to take some things forward more quickly than we otherwise might not have been able to? First to you, Gary. Thanks.
Yeah, I think it is a challenge, particularly if the approach to cardiovascular risk management is what we've had to date in primary care. Because of the obvious pressures on primary care, reluctance of people at the moment, although we hope that will change in a few months with vaccination, to engage with face-to-face visits. But on the other hand, I do think that there have been opportunities, and people have been thinking, okay, so what can we do in the new world? And some of this is coming out from, not just from advocates like ourselves within the CVD world. So NHSX, for example, picking up ideas around the importance of blood pressure management, are in negotiation to get funding for 70,000 blood pressure monitors. Many of you may be familiar with that, to distribute to improve self-monitoring. Now, self-monitoring blood pressure was something I was working on with Richard McManus, who's leading the research on that, and I'm a collaborator. So I think we've really got an opportunity to kind of push out approaches we were saying we should be doing anyway with self-monitoring. Now, for both blood pressure and AF, with some of the technologies available now, where you can remotely diagnose AF with, apps you can send to people, or devices single lead ECG devices. I think we have to focus on more empowerment, more self-management. There's other approaches we talk about in our guidance of having virtual patient groups of giving lifestyle advice, for example, which I think is an excellent thing, and think about how you reach out into some of the harder to reach groups. Obviously, for lipid management, you've got to get a measurement. You've got to get somebody somewhere and get a blood sample off them. I think I refer to my comment about being more opportunistic about this. And if anybody over the age of 40, you haven't got a cholesterol on their record, you should take it. I mean, one of my frustrations is people come with a TIA to the emergency department. We run a virtual TIA clinic. They always get full blood count, U&E sent off. They always get a CT scan, even though they probably don't merit it. They never get a lipid profile sent. So then I have to rearrange, get that done off the lab. And it's kind of that approach I think we really need to focus on.
That's fantastic, Gary. And David, just some thoughts. I mean, just thinking in the context of what I'll call it family testing. I mean, one of the observations that I've had through the pandemic is, as I got redeployed to do something I hadn't done for a very long time, which is general internal medicine, but our FH nurses carried on working on FH, and actually were very productive during the first phase of the pandemic, particularly with respect to I suppose the concept of getting whole families at the same time. And of course, earlier on in the year, that was very easy to do, because you'd make a phone call and everybody would be at home. And I know our FH nurses were quite successful at grasping whole families at the same time, and they were pretty receptive at that time, because it was a distraction to all the other things that were difficult, well, are still difficult, but were more difficult perhaps earlier in the year. So any thoughts, David, around that? I suppose what, not necessarily heel prick testing, but the thought around family testing in the context of more virtual working, and perhaps some opportunities around that.
Thanks. Well, I mean, first of all, just to echo, child parent screening is family identification, and it's a mistake just to think of it as just identifying the child. The child is the entry point. Through the child, you identify the parent and then the wider family. So we should really be thinking about family-based prevention of premature heart attacks. And so I totally agree with you there. I do think there are challenges ahead because of the pressures on primary care for vaccinating a population, as I mentioned, but I think overwhelmingly think this is an opportunity for two reasons. One is COVID has revealed a can-do mentality. Certainly in my own practice, and I've seen it, and we've seen it everywhere. And this is a very can-do approach to prevention. We've showed that it can be done. It's actually quite a good narrative. Parents welcome it. They appreciate the possibility of preventing a heart attack early on, as well as preventing infection early on. So combining immunization with screening for cholesterol is an easy narrative to discuss. And we've seen from the Health Foundation work that the rate of childhood vaccinations did not drop during the first peak. And the appetite for vaccination is likely to be enhanced, not to be minimized as a consequence of the pandemic. So I think providing we get the narrative right, providing we keep it really simple and don't overcomplicate what we need to do here, I think this is something that primary care can take on board and just simply bolt on to the immunization program and regard it as a way of preventing premature heart disease in families. Fantastic.
And I'm just going through the questions which have just been coming up, and it's a specific question for you, David. Is it an observation around the possibility of identifying cases of non-paternity? We were just wondering what are the questions around thinking.
So it's a very good question, and it's a question that arose in 2012 when we submitted our ethics application for the study. And the attendee who asked that question is quite right. The way of handling it is to invoke the concept of a de novo mutation, because you don't want to break up families. But let's fast forward what actually happened in our study. Well, there were 40 children, about 40 children identified. And in fact, there was only one pair of parents where the father refused to be tested. Yeah. And whether that was because he wasn't sure he was the father or the mother wasn't sure he was the father, we don't know. But that's 1 in 40. The other father who couldn't be tested was living in Africa. That was not anything to do with a choice, I think. I suspect, in our study, 84% of parents who were offered screening took up the offer of screening. That's pretty high. But that still leaves 16% who declined the offer. And it's likely, I suspect it's likely that any family where the prospect of non-paternity is possible probably will decline testing. But I can't say that for sure. All we can say is that non-paternity rates do vary from country to country, region to region. We were concerned about it at the start of the study. We're less concerned about it now. If it does become an issue, a de novo mutation is the way to handle it.
Okay, thank you, David. So, Hamdran, I know you've got a couple of questions. I'll ask you to deliver those yourself, if I may.
Thanks, Dave, and thanks, David and Gary. Excellent talks. May I just ask a question to David first? David, the thresholds for considering FH I think in your study is lower than what you plan to do clinically. Is that correct?
The threshold in our study, we had to choose a threshold to work with, a working protocol. You've got to do that when you embark on any screening program, let alone a study. And there we used a threshold that was about the 99th centile. What we found in our study is that there was a large number of children who had FH mutations between the 99th and 95th centiles. Now, being in the top 95th centile cholesterol is still an extremely high cholesterol level for that age group. So where you draw the line, where you draw the cutoff in any screening program, in any testing program, is a balance between the extent to which you're going to need to do, in this case, genetic testing and your pickup rate. It could be the 94th centile or the 93rd if genetic testing was very inexpensive and easy to do. So the 95th centile is a judgment. but it's a judgment based on the fact that what you're doing is you're screening for the cause of heart disease. You're not screening for a surrogate marker. So in identifying individuals who've got a very high cholesterol, the cause of a heart attack, you can lower that, and you support that with finding an FH mutation in the majority of cases. So yes, it is a lower cutoff than we used in our study, but I think it's a reasonable cutoff to deploy in practice.
Okay, thanks.
And if
carry on, Andrew.
oh, sorry, and if you discover patients who have a mutation, because in your study there were more ApoB mutations than we expected from what we know so far, and if you discover patients who have a mutation but their cholesterol, like the parents, their cholesterol is not very high, I mean, what to do in these circumstances? And especially if you lower the threshold, then we are likely to find these type of mutation. And in patients who have a higher LDL cholesterol or total cholesterol, but there is no mutation, again, what do you suggest to do with these patients? Because the risk comes from the LDL cholesterol or total cholesterol, not from the mutation per se.
Thank you. We have got to be absolutely clear about this. What you've just described will never arise, because we are not measuring, we are not looking for mutations in children below the 95th centile. So I think we've all got to be really clear about that going forward. In our study, we found mutations in children who had really low cholesterols, which shows that having a so-called pathogenic FH mutation on its own isn't sufficient. By choosing a high cholesterol and then supporting it with mutation, you know you're identifying the group in the population who are going to be at highest risk of a future heart attack.
So for the clinical implementation, your threshold is higher than the study to avoid this?
No, in our clinical implementation, the threshold we're actually using is the 95th centile, not the 99th.
Right, so it's lower. Okay.
It's lower, but it will identify more people and is a reasonable balance between the amount of genetic testing you'll need to do and identifying a high-risk group.
So thanks very much, both. Dermot, I know you've had a couple of observations and also some perspectives on. We were having some discussion there on the chat around the case finding opportunities from screening in primary care.
Yeah, so the Northeast North Cumbria project, and it wasn't my project, it's now been submitted for publication, and I'm not either the first author nor the last author, but yeah, I was involved. But what we did was we actually used the NICE 2017 guideline update recommendation for searching primary care records, which set a higher threshold, which was something that really came from Steve Humphreys and Maria Fatima's paper, showing that you needed a higher threshold to add specificity and to give a reasonable yield for a diagnostic application of genetic testing. So we used the 9 and 7.5 above and below 30, and the corresponding LDL and non-HDL fractions where they were available. And that's where we filtered basically down to basically people with an extreme phenotype. And among those people, there was a high yield of positive mutations in people who accepted the offer of a genetic test. So what we found was that you were getting an equivalent yield, roughly speaking, to in primary care as to what we were achieving in the secondary care setting. In the secondary care setting, people have been referred in for an opinion because there's a high suspicion of FH. So the pre-test probability in the lipid clinic is higher than primary care. So if you lower the threshold to Simon Broom 7.5 for adults above 30, for instance, you're going to end up with far too many cases to evaluate, and you end up with, if you like, getting a less of an effective identification program just because you're swamped with low risk cases. So this way it's going to identify fewer people. We recognize that most of the people identified are over 40 because they've had a health check, and it certainly can't do what child parent screening is able to do, which is a universal approach. You're testing everybody in the population in that category. Certainly, you know, there is no universal screening in adults, and as David mentioned already, the overlap between affected and unaffected people diminishes as the time goes on. Age tends to reduce the specificity. So what we were able to do was identify a decent yield in terms of probands, and we were able to identify relatives. David will tell you that for every proband in England that's identified, you only get one relative. In our part of the world, it's about 2.5, but if you got all the relatives, as Gary's slide showed, there's quite a lot of people who we know are either a first or second degree relative of somebody with a known mutation. And the big thing is to actually see if we can round these people up, I think, or maybe to persuade them to come and be tested. And that's not always an easy job, I'm afraid. Child parent screening it actually could be, you know, a little bit easier to manage and isn't as hard work, really, I suppose.
Thanks, thanks. There's a couple of questions from the audience. I think the most popular question is around, and I think this is to not anybody in particular, but to the panel in general, is about the barriers to FH identification being the lack of FH services, and if we had primary care, we'll call it family testing in its broadest sense, and we have limited FH services to pick up numbers, this may preclude our ambitions. What do we think about that, particularly in the context of where we are with the NHS at present? So,
Well, I'd chip into that. I mean, I'd say that we were very lucky in our part of the world, and others have also benefited from the generosity of the British Heart Foundation in pump priming cascade testing services around the country. And where those have started, I think CCGs have readily recognised their value and have provided recurrent funding to continue those services in the vast majority of cases. And I think, you know, if genomic medicine services are available, and particularly if primary care are able to participate in identifying probands, you know, one nurse per million population, it's not a lot of people in terms of the big picture in the NHS. When you think what the total spend in the NHS is, that would be fantastic value for money.
But I think this person who asked the question got a point, because lack of genetic availability of genetic testing and lack of structured services is mainly to blame for identifying less than 10% or even around 5% of the cases. It is not the failure of case finding and cascade testing. I mean, up till now, we are still not taking the advantage of the health checks, for example. And I'd really like to ask Gary, what's his comment on this? And
well, okay.
We trigger thinking about FH with these health checks.
So I'm going to come in. Obviously, I'm not a lipid specialist, but I'll give you my observations on this. So first of all, there is not a well-established, robust system for effective, efficient referral of people for FH testing. I mean, I look at it, you know, as a cardiologist said to me, if I want somebody who comes in with, you know, in their late 30s with a myocardial infarct, I have to send them to the lipid specialist to get them tested for FH. It's no wonder that, and there's no system in primary care to do this properly. So what we are seeking to do is to put in a proper referral system. Now, we've got the similar problem at the moment. Why would you set up an FH system at the moment? Why would you invest in it as a CCG? There's no proper referral route in, there's no genomic medicine capability. So the next thing is you build the capability, the analytic capability in the genomic medicine services and the GLHs. So that's why the conversations, you know, David and I are having with Genomics England are key to develop that capability. And so then as we're putting out programs which identify patients who need testing, you know, you've got that capability, and then it has to be supported by by putting in place an FH service. So it is complicated because you've got to get lots of things in, created. And but this is true for any new service. I mean, I lived through developing a specialty with colleagues where there was nothing for stroke in 1992 when I started as a consultant. There's literally nothing. People were arguing over whether they should even get a CT scan. And so you have to just work out exactly, the first thing is, are we clear where we're getting to? So for me, if I'm thinking where should we be in 30 years time, we'll be identifying everybody at 1 year. We won't be doing this complicated screening people 40 to 75. That's not the best approach to do. So I'm more optimistic, and every single time you try and introduce something new in the NHS, unless it's a simple drug that's easy to prescribe and is cheap, people always say, oh, we can't do it because of X. That's just the nature of developing services. So, but I see all these barriers as being able to be overcome, particularly when you've got exemplars that you can show to people, like the Northeast, and it's why David's trial is so important. We know this can work. So yeah, there will be battles. We may have to turn off the testing of some of if the capability isn't there, but that is we can manage.
So in this case, I hope you agree that we need to have somewhere for the primary care to refer to, and also and to protect the genetic services, because they have a limited capacity. We need a filter at the primary care, and also another filter probably for the regional FH services, not to use the genetic testing unreasonably, and basically not to compromise the yield.
Okay, so I agree with you and I disagree. I agree we have a responsibility to set up a service route that only people with a high probability of having FH are tested, that we don't have, I think this person's got FH, I can send it in as whoever. And I think we can do that, and we will put quality assurance checks in, and we're working with Mark Caulfield, the head of Chief Scientific Officer for Genomics England, to make sure we do that. But if I was sitting there as a genomic medicine service, I would be looking at this not as a problem that I can't do all my other testing in rare diseases. I would be seeing this as an opportunity for the first time to show population impact of genomic testing. I would be absolutely grasping this, and some of our genomic medicine hub leaders are. So, I think it's a great opportunity for genomic medicine testing. They will make the case, and that if we provide the samples and we're getting the hit rate that we've seen with David and Dermot's experience, I am confident that will be invested in.
Thanks, Gary. I think there's a question. Another couple of questions. We're slightly over time, but Handrin's going to be closing us off shortly, so we will finish on time. So there's a couple of questions related. David, this is a question for you around the age of testing and how that fits in with immunisation schedules. Can you remind us when it was that the initial test is done and the repeat test, and how does that fit in the context of the current childhood immunisation programme?
Sure. So the 1 year immunisation, it's 1 year, sometimes in 13 months, is the Haemophilus influenza B immunisation. And the most current surveys from the Public Health England is that 94% of parents take their children for that immunisation. Sometimes children who should have had their MMR earlier but didn't have it, the MMR gets tagged on to that visit as well. So in our study, I would say it was the Haemophilus influenza type B immunization at 13 months that was the one we were going for, but some children needed more than one immunization on that visit. If you need to repeat the cholesterol because the initial one is really high, above the 99th centile, but you didn't find a mutation, then the opportunity for doing that, certainly in our study, was at 18 months, where children were getting the pneumococcal vaccine. So it is absolutely right. Whoever asked the question, it's important that we keep abreast, because Public Health and the Immunisation Service do change their schedules, but they've not changed the 1 year. And we would just need to look at piggybacking on what is already happening rather than trying to get parents to bring their children for yet another visit. I think that was the key to success in our study. We didn't ask GPs to create new infrastructure. We said, use your existing infrastructure. You may need to slightly reorganize who's in the practice on that day and which children you're inviting to certain clinics. So a little bit of internal reorganization, but that is eminently doable. And the less we tell them how to do it, the better. Because what I learned is if you're a control freak, this doesn't work. They will get there if you just give them the goals.
Fantastic. Thanks, David. I'm going to ask one final question and then I'll hand over back to Handrin. And it's a question which has come up around point of care testing. So that's close to the patient testing for lipids. I'm guessing that the question is around. Dermot first and then Gary, of course, pitch in. Any thoughts around the utility and perhaps challenges of point of care testing around lipids in the context of what we've discussed this afternoon?
Yeah, so David will probably be able to tell you that the original study used the Cholestack LDX system, which was a Lear product, which has now been superseded by the Athenian system, which actually is very good liquid-based cartridge system, which is what we are proposing to use in the implementation pilots. And we have been talking with Abbott, who basically bought over a Lear, and they're very enthusiastic. The retail cost per cartridge is something like £5 or £6. But obviously, if volume, sort of supply, takes off with this, it's likely to fall. These systems are widely implemented around the country. Some places have used it for health checks. A lot of places are actually using it for infection control with CRP measurements, others using for HbA1c. So there's a very large installed base of these machines. They're very easy to use and they use a tiny amount of capillary draw blood to actually give a result in 7 minutes for the cholesterol. David's study published in 2016 just used total cholesterol, and that's what this is based on. And any clinical chemist will tell you the simplest total cholesterol measurement is the most precise measurement and the one that will probably give us the best results. Ultimately, the additional information you get from those point of care systems could be an HDL and a triglyceride, which might help you resolve some of the diagnostic dilemmas, I suppose, in ones where you've got a negative genetic test result. But anyway, there seems to be a lot of experience already in primary care with these, and I expect the company will be more than happy to help people get set up and running.
Yeah, I've not got much to add to that, except to say clearly, I mean, we do a lot of work with point of care tests more generally, and obviously they have their value most when you need an immediate result to take action on, and we're looking particularly out of hospital testing for acute conditions. So there's a clear role for point of care testing in the childhood program for FH identification. Personally, yeah, I think for adult, why would one need to move to point of care testing? I would have thought we'd be using standard blood scan central laboratories personally.